Good morning, everyone. My name is Darshan Mehta. I'm the Associate Director of Education for the Osher Center for Integrative Medicine here at the Brigham and Medical Director at the Benson Henry Institute for Mind Body Medicine. And we welcome you to our grand rounds, our monthly grand rounds. So just a couple of one quick announcements. One is that our Integrative Medicine Network Forum is next week on Friday, November 16th. And so all the details are on the Osher Center website. And as you know, we have our grand rounds on the first Tuesdays of every month. And next month, we have on December 4th, we have Dr. Ted Kapchuk, who is going to be, his title, as provocative as always, is Making Placebos Honest. So please do attend it. It will be a real, he's really changed, been very influential in the field, and it's an important luminary. We don't have grand rounds. The following Tuesday is the New Year's Day, so we won't have grand rounds. So this will be the last grand rounds next month for this calendar year. Okay, really it's my honor and privilege to present my colleague and friend, Suzie Bertisch. Suzie is Assistant Professor of Medicine at Harvard Medical School and recently shifted to the Brigham as the Clinical Director of the Behavioral Sleep Medicine program at Brigham Women's Hospital and at Faulkner. She has an extensive research career thus far and has really been one of champions in thinking about non-pharmacologic approaches to sleep. So with that, Suzie.
Thank you, everybody. Good morning. I hope everybody had enough caffeine this early in the morning and slept well. I'm really excited to be here today. As Darshan didn't mention, I actually was a former Osher fellow, so it's always exciting to come back and see my former colleagues and mentors and to talk about topics that's a real passion of mine that grew out of my experience as a fellow as well. I do receive some research grants from pharmaceutical and other industries, but they have no relationship with any of the information I'm presenting in the talk today. So to start, just so we're all on the same page, what is insomnia? So insomnia disorder is actually defined in the DSM-5 as at least 3 months for at least 3 nights of difficulty falling asleep, maintaining sleep, or early morning awakenings. And in addition to just symptoms of insomnia, can everybody hear me in the back? Okay, good. It's associated with significant impairment of daytime functioning. And in order to receive a diagnosis of insomnia disorder, the sleep problem cannot be accounted for by another sleep disorder, such as sleep apnea, a medical problem, a substance issue, or psychiatric conditions. It doesn't mean that these things can exist, but in the setting of insomnia disorder, you think that these conditions may be comorbid, but not ultimately the root cause that's so severe that that other medical or psychiatric condition needs to be treated. So now that we talked about what insomnia is, what is insomnia not? Because there's a lot of misperception about what insomnia is, because there's insomnia symptoms that belie many medical, sleep, and psychiatric disorders, but those are distinct from what we call insomnia disorder itself. So insomnia is not sleep apnea. It's not circadian phase disorder. The common one mimic we see in clinic is a delayed phase sleep syndrome where people have difficulty falling asleep for hours. But once they fall asleep, they can sleep 7, 8, 9, 10 hours a night. It often interferes with how they feel during the day because it's difficult to live in another time zone, essentially, in Boston. But these are all important sleep disorders or mimics that can interfere with sleep but are not insomnia symptom. And this is important because the treatments for insomnia are really specific to insomnia disorder and not to other sleep disorders are treated using different means as well as other, obviously, medical and psychiatric conditions. So in our current thinking of insomnia and how we defined it, we used to talk about secondary insomnia. So insomnia, if you had depression or anxiety or even hot flashes, in order to cure the sleep disturbance part of that, you needed to really treat the underlying disorder. So the focus of care was, if you can get rid of all the hot flashes, the insomnia will go away. If you treat the depression, the insomnia will go away. And we've realized that that's actually not the case, and the insomnia can persist even in the absence of these other conditions. And then the latest terminology that we use in sleep medicine is insomnia as a comorbid disorder. So you can experience insomnia with all of these conditions, but in order to really treat the sleep problems, you need to target the insomnia. So that's just a little bit of the background of the current thinking of how we conceptualize insomnia disorder and differentiate it from just more general insomnia symptoms that are often have other causes. And part of the clinical evaluation is really understanding where your patient falls on the spectrum and what are the attributes that may be interfering with their sleep. So today we're going to present the case of Amy, who is one of my patients, and we're very grateful for her to be here today. And she presented to my clinic, this is actually a few years ago, with dissatisfaction with quality and quantity of sleep for over the past 5 months. In terms of her sleep history, she was getting into bed and turning off the light about 10:30 in the evening, and it was taking her variable time to fall asleep. So some nights she'd fall asleep earlier than others. Other nights it would take her a long time to fall asleep. And that's very common of people with insomnia. Similarly, the number of awakenings in the middle of the night were also variable in terms of both number and the duration of those awakenings. She reported awake time as 6:30 in the morning, estimated a total sleep time of about 6 hours per night, and said she did not nap. And that's actually extremely common with people with what we used to call primary insomnia or insomnia disorder, despite being dissatisfied with their sleep, having interrupted sleep, and perhaps even shortened duration of sleep at night, they actually lose the ability to nap during the day. So most people with true insomnia disorder can't nap. They'd love to nap. They feel tired, but their body just won't do it. And in the review of systems, and I didn't go through the whole comprehensive medical history, but there were no clear other medical disorders, mood symptoms, or anything else really as acting as a primary driver of insomnia. She had no other symptoms of other sleep disorders. She had generally very good, what we think of sleep habits. She drank 1 cup of coffee a day, and a negative review of systems. Her previous treatment really encompassed mostly pharmacologic therapy. She was prescribed a variety of different medications, and this is very common because there's many medications we can try, and some work for patients and some don't. So those included Zolpidem, which the brand name is Ambien, that helped initially. Alprazolam, also known as Xanax, helped initially but had side effects. She was prescribed trazodone, which she thought was ineffective, and she had recently tried a short trial gabapentin, which also did not work. So when she came to me in the sleep clinic, it was the first day we really just did an assessment, and she was interested in using behavioral treatments for her insomnia. She hadn't responded well to several of the other sleep medications. She felt that there were side effects from the medication. She can speak more to that, but she was interested in behavioral treatments, which is really the first line recommended treatment for insomnia. So at the first visit, I just asked her to keep sleep logs for a month and to come back. And the behavioral program we talked about doing, because there are a few different ones to try, is called Brief Behavioral Treatment of Insomnia, which I'll talk more about later this morning. And since she had no other real comorbid issues, there was no other adjunctive treatment to try. And in the meantime, just because she felt that she was getting some benefit from the Zolpidem, we were going to continue on that. But really the ultimate goal was to not just getting her to sleep better, but to ideally wean her off this medication that we know may possibly cause side effects, particularly in the longer term. So when she came back a month later, and this is, I just set this up. Oh, sorry. And so for the behavioral treatments of insomnia, now this is going to sound really simple, but I'll have even talked about that it's actually a lot of hard work. The 4 rules of BBTI are to reduce the time in bed. So she had been going to bed, spending about 8 hours in bed, so we reduced that to 6.5 hours. So we're limiting her time in bed. She was instructed to get up the same time every day. She was instructed to go to bed only when sleepy and not to stay in bed unless she's asleep. And in the meantime, she was going to continue on her Zolpidem at this time. And then at a minimum of 2 weeks, we were going to talk either by phone or through email, our protected patient information email system about how she was doing. Did we need to make adjustments in her schedule, either because it wasn't helping or she was feeling very sleepy, and make changes over the course until we see each other a month later. So she came back to clinic. She reported that when the night she used the sleep medications, she was sleeping over 6.5 hours a night. So she's actually spending more time in bed than I had wanted her to. But her sleep was really fragmented the other nights. So the suspicion was that she was sort of the sleep medication was helping her actually sleep a little bit too much. So because our goal was to get her off sleep medication, we reduced the sleep medication a little bit and then tightened up her time in bed. And this will make more sense as we go through the rationale of how we use these behavioral strategies and how it integrates with actually some sleep physiology. So because we were pulling back on the medication, we also limited her time in bed down to 6 hours. And again, the same rules, getting up the same time every day, not staying in bed when you're sleepy, and only going to bed when you're sleepy. There were some email exchanges over the telephone at 2 weeks. After she had done well on the 6 hours of the 6 hour limit in bed, we extended it to 6.5 hours, and then we extended again to 7 hours. At 7 hours, our sleep started to get a little bit worse again. There were some environmental barriers, including her cat in the bedroom. But at this time, she had been doing fairly well. We decided to discontinue the zolpidem entirely, bring her back down to 6.5 hours since we were discontinuing the medication, and again, the same rules and follow-up. Just so you know, this time frame was a little extended. Sometimes BBTI was really intended to be more of a 4 to 6 week program. This was extended, which sometimes is needed with drug tapers and just from other sometimes scheduling issues. But really at the end of her treatment course, and this happened to be 6 months later when I saw her in clinic, part of because I was out for a couple of months on maternity leave, but she reported much improvement in her sleep. She was now sleeping from 10:30 at night to 6 in the morning. She did have occasional difficulty staying asleep, but it was not a problem for her, and she reported a marked improvement with the resolution of her insomnia. So with that, I'm going to turn the microphone over to Amy so she can share her story with us.
Good morning, everybody. Well, I'm Amy. I started having problems with insomnia probably around 2015. And at first I thought it was a genetic thing because my brother had problems with insomnia for a while. And it had never really happened to me in my life. He started having it when he was an adolescent. And he's been struggling with his sleep most of his life. But it didn't start happening to me until I was in my 40s. So this was in 2015. And I remember talking to my brother, and I didn't want to go on meds initially because I usually have bad side effects from medication. So I looked into other things, like I did more exercise, thinking that would help me sleep more. It didn't work. I did transcendental meditation for a while, but that wasn't really working. I have an aunt who's a Reiki master, so she gave me some free Reiki massage for a while, and that wasn't working. And then eventually I just kind of gave in and went to my primary care physician, Dr. Ship, and she prescribed me some medicine, and some of it was working and some of it wasn't. I was getting weird side effects from a lot of it. I felt a little disoriented the next day, or kind of like a zombie, and I slept a little bit, but I was still just feeling almost worse. It was almost better being sleep deprived than feeling drugged the next day. So like Dr. Bertisch said, I went through a period of different medicines, and eventually zolpidem or Ambien ended up working for me, and that's what I use now when I have problems sleeping, because I still occasionally have problems sleeping, not as chronic as it was 3 years ago. But then Dr. Ship, after having problems for 5 months or so, Dr. Ship recommended I see a behavioral therapist, and she referred me to Dr. Bertisch, and that eventually helped me to sleep permanently. It was amazing. So she just, put me on the schedule where she limited my sleep time. Like I started going to bed at midnight, which I was really reluctant to do because I was like, I have to go to bed at the same time. But, I just forced myself to stay awake, and then I, slept until 6, and, sometimes it worked, sometimes it didn't. But and eventually I would add on more hours to that. So it would be 12 to 6, and it would be 11 to 6, and then eventually 10:30 to 6. And over the course of a few months, I think it ended up working for me. And the more I kept to the schedule, the less I needed to use the Zolpidem. And to this day, I still kind of follow that. I'm pretty militant about my sleeping. Like if I go away or I'm staying at a friend's house, I'm the loser who goes to bed before everybody else. And, you know, I try not to drink too much, and I don't drink any alcohol after noon. I don't take any naps, and I try to go to bed the same time every night, even when it's on a weekend, and get up the same time, which stinks because, you know, I'd rather sleep in, but I'm like so paranoid that I'm going to go through that period again, and I never want to go through what I went through that year, because it was probably one of the darkest times in my life. It was awful. I don't know how many of you have struggled with sleep disorders, but it's a nightmare. It's like you really do want to sleep and you can, and like the whole nap thing, like your body won't let you take a nap, and it ends up, you know, messing with your evening sleep anyway. So anyways, that's my story, and I highly recommend that option if you are someone who is struggling, because it really worked for me. And I like Zolpidem too, that does help, but I try not to take it all the time, but you know, if I need it, it's there. So that's about it. Thank you.
So now we're going to talk a little bit about the treatment of insomnia. So I always find this cartoon really funny because it actually hits on a lot of elements we talk about when people have trouble sleeping. You know, what you'll see is we actually strongly recommend people not to stay in bed unless while they're awake at night, but we'll get to that more. So in thinking about conceptual models of insomnia, there's actually a number of conceptual cognitive models that are out there in the literature, but the one most common and the one I thought most relevant to present today in terms of the psychological background is that of the famous Spielman 3P model. The 3 Ps are predisposing factors, precipitating factors, and perpetuating factors. So predisposing factors, so these are the ones down here, are really sort of your background risk, your differential risk of what might make you more predisposed to insomnia versus other people. And this can be things that change over time, like your age, or as Amy mentioned, she has relatives in her family who also may be susceptible to sleeping poorly. So this just is sort of why some people may develop insomnia and why others may not. Following your predisposition or the precipitating factors, and these could be a host of physiologic, psychologic, environmental stressors that happen, you know, rather acutely, that then bring on the onset of insomnia disorders and sort of put you past this hypothetical line of when your symptoms start that throw you into this insomnia pattern. And then the third factor that's discussed in this model are perpetuating factors. So these are behaviors that prevent or reestablish the normal sleep pattern. So things like, you know, spending a lot of time in bed, trying to do other activities that interfere with sleep. And that's what you see here. And then the thought is that over time, as you really develop these maladaptive behaviors, that helps to perpetuate the insomnia, even as the initial acute stressor go away. So this is really a sort of helpful heuristic model, and it does have some clinical utility in that it really helps us to dissect the patient's story and try to identify what are some possible targets, like what may have brought on the insomnia. And sometimes we can't identify the predisposing cause, but I think it does help you contextualize their experience. But it really lacks any specificity. It's not really strongly tied to neurobiology, but it is one of the models that's persisted really from a psychological perspective, and it does inform some of the cognitive aspects of treatment in terms of really trying to have people unlearn these perpetuating factors and really develop good skills. So there's a newer model, though, of insomnia that I wanted to present briefly today that they're calling the neurobiocognitive model of insomnia. And in order to understand what they're proposing in that model, and something that I think is really essential to understanding when we think about behavioral treatments of insomnia, is actually what controls our sleep and what regulates our sleep. So these are actually more simplistic diagrams of the neural circuits that control sleep. And so this is our wake system, this is our sleep system. So the awake system, otherwise known as the ascending reticular activating system, really controls when we're awake. So for wakefulness to occur, there's an engagement of multiple brainstem and hypothalamic nuclei that then ascend all the way up with their projections through the cortex. And as I said, there's multiple nuclei this occurs in, and these are actually some of the pharmacologic targets we use to treat insomnia. So for instance, there's the tubulomammillary nucleus in the posterior hypothalamus that's a histaminergic nuclei. So when people report sedation with antihistamines, it's actually targeting those nuclei. Then there's also a separate system that's been described, and actually a lot of this work has actually been described by Cliff Saper's lab, who's at Bethesda Deaconess Medical Center. And they describe the activation of the ventrolateral and medial preoptic area that really initiates the non-REM sleep process. And even though there's those two separate systems, they actually overlap and working in circuit with one another. So one actually controls they're mutually inhibitive systems. So when the wake neurons are firing, they actually inhibit the sleep neurons and vice versa. So it becomes, sort of as a principle of electrical engineering, this bistable switch, which is otherwise known as a flip-flop switch. So we're generally either awake or we're asleep, and they control one another based on various inputs. So that's a model for global sleep, but there's also some evidence that sleep also occurs in other local use-dependent systems, even in specific aspects of the brain or even specific neurons of the brain. And so this group, primarily based in Pittsburgh, has put forth a hypothesis for this newer neurobiological model, which they described in 2011, and described insomnia as a disorder of sleep-wake regulation characterized by increased activation in a specific neural structures and circuits during non-REM sleep. So essentially, they're saying that there's part of the brains in these local networks are staying awake when the brain really should otherwise be sleeping. And that actually, if you listen to a lot of patients with insomnia talk, one of a common feature is that they'll say is that when I'm sleeping at night, it feels like my brain's awake. So actually, this hypothesis mirrors often what we hear in clinic. And what actually controls these circuits and systems is we'll talk about a second model of sleep, is actually there's two things that really control when we sleep and how much sleep we get. The first is called homeostatic process, or process S. Very simply, it's really just a sleep drive. It's how long you've been awake. So over here on the y-axis is our sleep drive. So when its sleep drive is high, your brain, it's time for your brain to sleep. And on the x-axis, this is actually time. So at 7 in the morning, my if I've gotten a good night's sleep, my sleep drive is low. Then throughout the day, my sleep drive goes high. When I go to sleep, it goes down again at night. If I stay up, my sleep drive gets higher. And we cycle through this day after day. And if you think about, I was talking with Amy with her Zolpidem, what I thought was happening was that when the mornings after she's taking Zolpidem, her sleep drive was lower, and by the end of the day, she just couldn't get up high enough and sort of set herself up for poor sleep. So working in concert with this homeostatic process, so I also tell my patients it's like a volume button. The volume's down on 0 when you wake up, and it cranks all the way up to 10 at night, and then you fall asleep, is the circadian system. So this is the 24-hour body clock that their body has. It's what we all recently experienced with the time change, and while we need some time adjusting to get back to this current time zone. And ideally, you want these two controllers to be in concert. So you want to have your sleep drive up the highest when it's the start of your circadian or your biologic night. So the whole these stronger behavioral treatments of insomnia do is use these controllers, and we actually, as I'll go through in a little bit, you'll see how we actually take over these processes and really use them and use behaviors to manipulate our homeostatic sleep drive to really try to get that high up, and then slowly take control of the system over time. And we're always doing so in concert with the person's own body clock, as best as we can tell what their body clock is, and we try to align these systems together really to optimize sleep. And I'll go through that more step by step, but that's the goal. And based on these controllers, so the homeostatic sleep drive, they control, as we mentioned in the first slide, the sleep-wake switching systems, the flip-flop switch, the brainstem hypothalamic arousal system. So we manipulate these drives to impact these sleep-wake regulation centers. And then there's also a cognitive component to sort of really influence the upper affective circuits or maladaptive thoughts. And so treatments for CBTI really are focused on the cognitive treatment and behaviors around working with these systems as well to then sort of take over regulation of the sleep system. So in talking about treatments for insomnia and how we do that, I always think it's important to remember what our goals are. And it's really important to know that when we treat insomnia, our only goal is not just to improve sleep, and sure, that's a large primary target, but the other goal is really to improve daytime function. How are they feeling during the day? And we want to do that also with as minimal adverse effects as possible. I'll just note that there's also some sleep research that we're trying to look to see if we improve sleep, can we also improve other comorbid conditions, and that's a lot of where our field is looking to now. When we discuss treatments for insomnia, we really think about two separate types of treatments. So pharmacologic treatments, which are medications, and behavioral treatments, and sometimes we utilize both. So briefly, medications for insomnia. We know that they're commonly used. In a survey using NHANES that we did, we found that on any given month, there's about 3% of people in the United States are using a sleep medication. And the most common one is actually zolpidem, followed by trazodone, which this is not FDA approved for sleep, and there's actually very little efficacy data on its use. So it's actually very interesting that it's used. But some of the more interesting finding was that more than half of people taking one of these medications for insomnia were taking another sedating medication, such as an opioid or a benzodiazepine that's not commonly used for insomnia. 10% were taking at least 3 other sedating medications. And there was a question that asked, did you just use a sleep aid? So this actually comprised of not just prescription medications, but we also think over-the-counter medication. And over 19% of American adults reported in the past month that they used at least one medication to sleep. So that's 1 in 5 medications using medication to sleep. So this is really has a real impact in people's lives. So this is really not meant to be a comprehensive list of medications for sleep. These are some of the different categories, but what I really wanted to look at is the potential disadvantage of the medication. So we did talk that some of them have limited efficacy, but even the ones that are FDA approved are known to have cognitive effects, higher risk of falls, and we see this down the category, anticholinergic effects, risk of falls, limited efficacy data, limited efficacy data, limited efficacy data, and usually when there's limited efficacy, there's actually also no data on safety as well. So there's a lot of limitations to using sleep medications, because the problem is, how do you get a medication that helps you fall asleep without any sedating side effects that puts your body at other risks? So this is sort of what I personally think is really one of the many things that's appealing at using lifestyle treatments for sleep disturbance. And these really comprise of a diverse set of behavioral prescriptions to improve not just even the quality of sleep, but improve patients' lives. But they all involve some change on the patient's behavior, and they all use voluntary waking behaviors to influence the sleep-wake balance. The very first step before we even get to the behaviors, though, is actually sleep education for the patient, because it's important for the patients to understand why is it you're asking them to do things that are very hard. It's hard to really revamp your whole sleep schedule to make sleep a priority. To the nights that you don't sleep well, you're going to be really tired the next day. And, if you have a job or things to do, it's really difficult. So the patients really need to understand why you're asking them to do these things, because they need to be able to adhere to the treatments in order to get them to work. So we also explain simple things like sleep is, we have voluntary behaviors that influence our sleep, but sleep ultimately is involuntary. We can't sleep when our body is not ready to sleep. We have a wakefulness center, we have part of our circadian system, where we're supposed to be awake. That's why it's hard for us to attain sleep during the daytime. We biologically can't do it. So lots of times people with insomnia sometimes think giving them a sleep medication, you can knock them out and make them go to sleep. But even with the strongest sleep medications, we can't put the brain to sleep if the brain's not in the state or ready to be asleep for a variety of reasons. So, and we do educate our patients about the two models so they can understand how their decisions and behaviors may influence how they're sleeping the next day. So if they want to sleep in for a morning, know that if you sleep in, you may set up for a worse night's sleep the next night. So there's important, by understanding a little bit about what controls sleep, it also empowers them and gives them another perspective of how to actually make their sleep better. And it's also important to set realistic expectations. They're not going to all of a sudden sign up and be able to sleep 9 hours a night on command, but they just need to sleep enough where they feel like the sleep is not frustrating, it's not anxiety provoking, and they can really perform their best the next day. So usually what most people think about in terms of behavioral treatments insomnia really are part of a diverse set of practices called sleep hygiene. And there are sleep hygienes usually practices that hurt sleep, and the next help sleep, and the next slide we'll see practices that hurt sleep. So these are all things that most people and really anyone with insomnia already know. It's important to exercise, have daily routines, treat any underlying medical problems, sleep in a comfortable environment. And these are sort of, if you think of like a step care approach, these are important for really anyone to do to help them sleep better. But as you'll see my warning down here, they are necessary, but they're not sufficient treatments for insomnia disorder. So when you see the patients who've tried everything for insomnia, we know that these are generally ineffective in reversing insomnia disorder. In fact, they're used as the control arm in clinical trials of insomnia. So as I just mentioned, these are practices that help sleep. These are things that hurt sleep. This is not a typo. It's really the number one sort of sleep thief we see these days are people on their cell phones and tablets at night. It's not only cognitively stimulating, prolonging bedtimes, but there's also the issue of light potentially interfering with the body's own natural onset of the biologic night. Alcohol, caffeine, nicotine, again, these are all things that can interfere with sleep, and it's important really first step. And some people really who are evaluated in the primary care setting with this information will get better, because lots of things that we do see in primary care are people just with poor sleep habits or not understanding their sleep habits. Regular wake time is also very important if you think of sleep hygiene, but again, people who are coming back doing all the right things, you really need to consider that they may have insomnia disorder. Just very briefly on people who do need tablets, there are specific, orange glasses, things you can minimize the blue light exposure. But again, this is more of a sleep hygiene technique or people with circadian rhythm issues, and again, not necessarily treatment for underlying insomnia disorder. So in 2016, the American College of Physicians came out with a practice guideline on treatment of chronic insomnia. And this is really a shift in our field, where the first recommendation was that all adult patients receive cognitive behavioral therapy, or CBTI, as the initial treatment of chronic insomnia. And part of the evidence for this, and this is actually an older study, but I just think it's a nice slide and shows the comparison, is that if you look, so sleep latency, so that's the amount of time it takes you to fall asleep. So these are drug studies, and these are behavioral studies, and it shows that they both show improvement in lowering, so it makes it both forms of treatment. Patients fall asleep faster, and wake after sleep onset this is how long you're awake in the middle of the night. And in both types of therapy, patients are, after they have treatment, spend less time awake in the middle of the night. And a lot of the studies have shown, or there's actually been just a few head-to-head small trials of pharmacologic reverse behavioral therapy that show that behavioral therapies are thought to be as strong as pharmacological therapy, and there's certainly ample evidence for their efficacy with really much more minimal side effects. So really, what is CBTI? I think if you take anything home today, this is the one slide, because it really defines what we mean as effective behavioral treatments for insomnia. So we already talked about sleep hygiene education. And sleep hygiene educations, again, we're trying to reduce behaviors that interfere with sleep, such as increasing arousal. Sleep hygiene is also comprised of sleep restriction therapy, stimulus control, cognitive therapy, and relaxation training. It's thought that these two components, the sleep restriction, stimulus control, may be the stronger components, and it's actually those form the backbone of brief behavioral intervention, which is what the treatment plan that Amy was on. And each of these actually have an aim and that are actually supposed to drive the physiology. So in sleep restriction, so this is limiting the time in bed, we're trying to increase the sleep drive and stabilize the circadian rhythm. So really, they have the normal sleep schedule. We're trying to turn that volume dial all the way up. And they get actually really sleepy for a few weeks. I tell everyone in 2 weeks, if you're really sleepy and you hate me because you're so tired, that's a good thing. That's showing that this is working, we got it right, just stick with it a little bit more. And we eventually, as you saw in Amy's case, we give the time back. We essentially take control over that system. We don't let them just sleep it all off with a couple of nights of really, 10, 11 hours sleeping in types of sleep. The other component we use is stimulus control, so really reducing arousal in the sleep environment. You want people's brains to be retrained, so when their brain really doesn't recognize other stimuli environment that keep them awake. So people with insomnia tend to spend a lot of time in bed because if they're going to fall asleep, they want to be there in case it happens, but it actually is not only frustrating, but it sends their brain the wrong message. We just want the bed to be only for sleep and no other waking activities. And then there's cognitive therapies, which restructure some of the maladaptive beliefs about sleep itself, but I'll say that every single component of CBTI requires cognitive therapy because you're educating, reframing things with patients, you're negotiating, you're coming up with plans together, so it's really not specific to that. And then I think relevant to a lot of the work that Osher does is a part of relaxation training. So these are really tools that can be utilized, and there's various forms of relaxation training I'll talk about in the slide. But the common thing is they're using all voluntary behavior to influence these involuntary physiologic processes. So again, this is the same slide I showed before. We have both the cognitive as well as manipulating some of how we're feeling here to then influence the neural pathways. Just a brief word, because I thought this crowd would be interested, there's actually a lot of work on mindfulness practices for most of the literature is more on general insomnia symptoms and not insomnia disorder, but I think an interesting part about it is we're generally just not getting people to relax to fall asleep, although that helps to people clear their mind, but really there's a movement to use mindfulness just to promote awareness of the mental and physical state, so having people assess, are you sleepy? Is it time for you to go to bed? And make them more aware of their body, of how they're feeling in different times of day, and how to utilize those sensations to help them improve their schedule. And for people who are interested, one of our colleagues in Chicago, Jason Ahn, literally wrote the book on mindfulness-based therapy for insomnia disorder. He's a very thoughtful clinical psychologist who's done some of the early work here. There's also some work not just on other forms of meditation, but yoga. Satbir, who's sitting here, has done some of the work for yoga, and also Tai Chi. Most of the literature, again, has been done on patients with just general insomnia symptoms. There's a lot of work in patients with cancer who have poor sleep quality. There's a few studies on insomnia disorder, and generally most of the studies do show that there are improvements in sleep quality, but again, sort of a monotherapy mindfulness is not necessarily going to be treatment for people with chronic insomnia disorder, but it's definitely a tool that we see widely used, and it's a skill that a lot of patients either to help them reduce their general arousal during the day, make them more aware of how you're sleeping, or actually being a tool for the middle of the night awaking to help them relax again to get out of sleep. So back to more traditional cognitive behavioral therapies for insomnia. One of the limitations, so cognitive behavioral therapy is generally set up as about an 8 to 12 session treatment meeting with psychologists. So it's actually both cost and time intensive. So there's a real movement to try to actually make these form of therapies more accessible to the public. So the one that I do in my clinic is called Brief Behavioral Treatment of Insomnia, and was really developed to be over 4 or fewer sessions, some of the treatment to occur over the phone. And again, the original studies were about a 4-week treatment time course. I do also want to point out that there's several online treatments, Sleepio, Shut-Eye. They actually just pulled Shut-Eye offline, but it'll probably come back in another form. But those actually have multiple studies that show that they're efficacious in people with insomnia disorder, so it's another option as well. So there's a lot of sleep research trying to figure out how to get these treatments for patients. So just getting to more specific about what I do routinely in my clinic, I'm not a psychologist, so I'm not as trained in cognitive therapy, but I've been fortunate to receive the remote mentorship of Dr. Bicey, who's at Pittsburgh, to learn to bring behavioral treatment to my clinic here, and even some of our work at Beth Israel, we even trained one of the social workers in the primary care clinic to deliver this intervention. So it's essentially just briefly, it's 4 steps. Again, sounds easy if you're not the patient doing it, but the first is to reduce your time in bed. And in the red up here is sort of my comments of what we're actually trying to do. So reducing your time in bed, it's a form of sleep restriction, driving up that volume, trying to crank it all the way up to 11. You didn't get the Spinal Tap joke. I thought you would get it. Get up at the same time every day, no matter how much you slept. That sets your clock. Don't go to bed unless you're sleepy. So this is both stimulus control, trying to reduce the frustration, also increase their sleep drive. And again, we don't actually set a bedtime. We just say you can't get into bed before this time. So if you're feeling sleepy before that time, try to stay awake. If you're not sleepy at that time, stay up until you feel sleepy. And don't stay in bed unless you're asleep. Again, stimulus control, reducing frustration. So in our clinic, I actually use the treatment manual from Pittsburgh, and this is just one of the pages that that we show. We go through each of the rules with the patient and actually just show them how it actually influences their sleep controller. So we show them by cutting, when we talk about reducing your time in bed, we talk about cutting down your time in bed, increasing the amount you've been asleep, because we want you to go to bed when you're up here and not down here. And also explain if you're tired and take a nap, you know, you're going to go here, and then at the end of the night, you're going to wind up down here. So reducing your time in bed, the longer you're awake, the easier to fall asleep. You'll have a deeper sleep. And also explain, it's important for them to understand we're not actually decreasing the amount of sleep they're getting. We're actually just limiting the time in bed. So in Amy's case, we took out about that hour and a half of bed she was spending in bed every night and just limited her initially to the 6.5 hours of sleep. And the way we figure out, again, it's not exact. We look at their sleep logs and get an estimate on average about how much they slept each night over the last 3 to 4 weeks. And then we add about 30 minutes, to give them time to get into bed, time to fall asleep, waking up in the morning. And we really try to restrict no fewer than 6 hours of sleep a night. And once in a while, sometimes we try to do that, but that's what they start. And then we actually go through each separate rule and follow the similar explanation. And then at the end, again, so this is a lot of education reframing, they get a sleep prescription. So they leave a clinic with their tailored sleep prescription. We go through the rules for better sleep. In this case, wake up no later than 6:30, bedtime no earlier than midnight. Their total time in bed is 6.5 hours. Continue the sleep medication for now. And they do sleep diaries throughout. Because we always want to know how much are they sleeping at night, but also when are they sleeping, so we know exactly how to choose the wake times and manipulate it. And then, depending on how they're doing, we may extend or reduce the time in bed. Or if they have a lot of rumination, we talk about ways to minimize rumination and things like that. So that's the end of my presentation. So before we go into the discussion, I wanted to introduce our third speaker today. Did you want to say something? No? Or do you want to? Sorry. Or we can just go on the panel. Okay. All right. So we're going to stay open for questions now. And you already heard from Amy, and our other panel discussant today is Amy Shipp. So Amy's an internist and she's currently here at Brigham and Women's Hospital at Atrius Health, and she's assistant professor of medicine at Harvard Medical School. And she's I can tell from having worked with her in the past that she's an excellent primary care doctor, and I'm really interested he always has wonderful insights. So I'll turn it back over to Jessica or Darshan to moderate our session. Thank you for your attention.
Thank you, Suzie. Amy and Amy, please come up front. So what we want to do now as part of our clinical grant rounds is interactive. We want to encourage questions from the audience and maybe just while people are just sort of gathering their thoughts, again, thank you for Amy, our patient, for presenting. Amy Shipp, thank you and I want to invite you to say just a couple words while people are gathering their thoughts. As a primary care provider, what sort of this means and how has this reframed your understanding of how we treat sleep in the primary care setting? And Suzie, fantastic presentation, thank you. And more, I'm sure many people have questions for you. So Amy, maybe you want us to just say a couple of words on what does it mean in primary care now?
So thank you for having me. I think there are a couple of things that struck me during the presentation and in my recollection that I wanted to share. And one that I'm struck with that's not manifest here is that when Amy had horrific insomnia, it was horrible. And horrible is an understatement, and that's my perception from afar. And so I think just recognizing when people have severe insomnia that they can't get out of. I think we all know kind of personally how hard it is. You can't sleep, and then you become overwhelmingly anxious because you can't sleep, and then you can't sleep because you're overwhelmingly anxious, and it's a vicious, miserable, horrible cycle. I really want to hear to get rid of those ruminative thoughts, but that's just selfish. So I just want to name how horrible it was. Either it's been suppressed or it's been a long time ago, but it's a really miserable, interferes with daily function kind of disorder. And so I think recognizing that is a start. I also think by the time Amy got to Dr. Bertisch, I had tried at least 4 medications, at least 4. And that was in somebody who really didn't want medication. And that's a little unusual, I think. And I think that has 2 parts. One is that in a vicarious way, I wanted to fix this, right? And I think we all want that, which is sleep behavioral modification is hard. Changing your behavior is tough. And what I wanted as a doctor is what's very difficult is to turn on, here, go to sleep, sleep well, wake up, make it better. And so I think it's challenging. Amy was unusual in that she tried a lot of stuff on her own. Her sleep hygiene was really, really good even before she came for consultation. And she was actually not that interested in medications. In my personal experience as a primary care doctor, most patients are not in that category. They're very interested in medications. Just make it better. And I think as a clinician, I was really, really frustrated that I couldn't make it better. So we tried 4 different medications. I'd say each of them initially worked reasonably well. So there was kind of like, oh, we're okay. And then they failed to work. And so it was very, very difficult. And it's a very challenging and I think psychically overwhelming experience. So I was very, and the other thing that wasn't mentioned here, there were several medications. There was a visit to a psychiatrist to see if there was anything else we could address that might be behind it. There was a visit to, or more than one visit, to a sleep psychologist. So several visits. Yeah, there was.
I blocked a lot of this out because it was a dark period for me.
Yeah. Sleep psychologist to, again, attend to non-pharmacological approaches, and then finally to Dr. Bertisch, who came, raves about her capacity to make a difference. So anyway, very, very, very overwhelming problem. I'm glad you suppressed it, but it was awful for me.
Thank you, Amy. No, I appreciate that wonderful insight. So wanted to open up to a question. Start with Sep here and then behind Sep.
So my understanding is that the cognitive therapy has really good evidence because there have been trials of cognitive therapy alone for insomnia, which have been very effective, and that's been one of the major components that's been in the formal 8-week CBTI program. So I'm a little surprised that Dan didn't include cognitive therapy within his brief intervention, because a lot of brief CBTIs have included cognitive therapy, which includes not just the dysfunctional beliefs and attitudes, but also dysfunctional rumination before sleep onset and during mid-sleep awakenings.
So I've never asked, this is Dan Bicey at Pittsburgh, who's actually a sleep psychiatrist, is his training, who wanted in trying to make it more available. So the original, I've never asked him directly why he hasn't had cognitive therapy, but I think I have a little bit of insight as to what he may have been thinking. So one is there's some evidence that's, sleep restriction, stimulus control alone are really powerful. I think he would also say that all of these behaviors have some form of cognitive therapy. And again, this is thought not just to be and his main goal was really to make something that's practical in the real life. And the original BBTI study that was published in 2011, as their interventionists, they didn't use sleep psychologists, they didn't use sleep MDs, they didn't use general psychologists. They used it was a nurse practitioner with no training in sleep, and a lot of their subsequent studies are actually social workers who also start off with no training in sleep, so they can learn the techniques. And I think having done this myself and not being a psychologist, I feel like that's the one part of the therapy I'm not trained to do. So I think in trying to apply it to other manualized programs, some of the cognitive therapy was not addressed. But in having also talked to Dan, I think the goal is, theoretically, you can get them tired enough that when you drive up the sleep homeostat high enough, it just overwhelms the cortical arousal system, and as people are able just to fall asleep because they're so tired. And that's what we actually see when most people come back. I've had very few patients who can actually stay up to the bedtime that we recommend. I mean, I don't have patients who are sleeping later than the sleep restriction. Where they have problem is usually waking up before the wake time. So in the experience is to overwhelm the system. So I can't speak for him, but I also know he will talk about the cognitive aspects to delivering the therapy in trying to address the thoughts. But I've never asked him specifically why I think it's mostly for practical, pragmatic reasons and trying to train people up. I think that's the hardest part to train people in. I can ask him though and get back to you.
Well, I mean, it would make sense for you to incorporate it as well. I mean, why not add it?
Well, I think it's also meant to be done though in a 20-minute clinic visit. You know, so I have 40-minute new patients, 20-minute follow up. It's a matter of what gets left out. So I can do this manual and do the follow up. So it's just a matter of time. And I'm not saying this is the end all be all when I have patients who don't succeed or patients I think are too complicated. So if I have patients with a lot of anxiety, a lot of rumination, patients with ADD, patients with PTSD, I refer them to CBTI. So this is, sort of for those patients. So I try to map the therapy, or if I do BBTI patients and it's not working, then I send them to CBTI just for another perspective. So it's not saying that they're not getting any cognitive therapy at any point. I try to figure out who matches well with what I'm able to offer them. And when we go through the assessments, I go through, these are your options. We're grateful in Boston. We have CBTI people. I do this program and explain it to them. There's also online options. And so I have patients really try to devise a preference for behavioral therapies of what might work, what they think they can actually do given a lot of other external constraints.
Next question.
Thank you very much for your interesting and helpful presentations. I was tested for sleep apnea and I have mild sleep apnea, but I had a lot of arousals during periods of time when I wasn't having an apnea event. And so he termed it light sleeper. And over the last couple of years, I've had big bouts of insomnia that really impact my day. I'll be up for 2 to 4 to 6 hours. And I get out of bed when I'm not sleepy, and I'll end up doing something. But I don't know what to try. I don't want pharmacological intervention. And so I'd love to hear some recommendations or thoughts. Thank you.
So maybe I'm going to just invite maybe from typically from a primary care and then just from the patient perspective, what has been your experience? Like, what is the journey? What is the typical pattern? And then maybe Suzie, you can just add a little bit on how's the pattern changed now? Yeah.
So I'm not going to address your particular circumstances because I wouldn't be able to. So I'm a primary care doctor, so a specialist in nothing at all. And so my knowledge is a combination of whatever experience I've had and then life. And so when somebody comes in with a sleep disorder that's new, one of the first things I try to elicit is what's changed in their life. Because as with many symptoms, sometimes something precipitates a change. And so sometimes I explore that. I always address sleep hygiene first. For those of us who are familiar with sleep hygiene, it's kind of a given, but there are lots and lots of people who just don't know how to. And I think in a sort of way, it's a very, very mild form of behavioral modification. And so I address that if it isn't being followed to see. And then I try to give, ideally, non-addictive or medications that don't not habit forming, to help people, because I think like many behavioral things, you need to sort of break the cycle, and you want to get to a point where you get a good night's sleep and you feel kind of confident that you can get there again. So I try to do that with an idea to kind of break the cycle and then try to wean off with a little bit more comfort. A tiny thing I also do is I recommend people try things on a Friday night and not during the week, because if it throws you off, you don't want your life thrown off yet more. I'm not sure if I answered your question, but those are the
And Amy, if you had one point you would want to say, like, look, having reflected on your journey, what is one thing you would have thought, oh, I wish I would have done this earlier, or done this, or was the journey exactly as you thought it was going to be?
Pretty much what I expected. I mean, I wouldn't have immediately gone to the pharmaceutical route. Again, like what Dr. Shipp said, I wanted to avoid that because I always have such bad side effects from drugs. But just limiting my sleep time was the best thing that ever happened to me. And that's basically what changed everything. And then just to be consistent and go to bed the same time every night and get up the same time every morning, regardless of what day of the week it was. And when I had problems falling asleep, I would get up and read. It didn't always help, but I would not watch television. I would not look at my phone. I would not listen to the radio. I would just try to read something really boring or something that I had a hard time focusing on. Like Entertainment Weekly, the font's gotten smaller for some reason the past 2 years, or I'm probably losing my vision as well, but I would read Entertainment Weekly. I don't know why that would help me fall asleep, but because I could barely focus on what I was reading. And then I would just go back to bed. I wouldn't always fall asleep. And white noise helps me too. That's always helped me. I usually sleep with a fan on or have a white noise machine. That's helped. I know everybody's different, but that seemed to be the combination that helped me.
And then Suzie, if you can just as a sort of final thought or comment, I would say, what are the resources right now in the Boston area around sleep clinics? And I know you're part of a big one, but are there, is this just unique to your clinic or others are available as well?
Yeah, so all of the most of the major medical centers have specific, sleep disorders clinic. Generally, the access is not great for them. There's minimum of 3-month waiting list around the board. There's also, and they all do routine testing for sleep apnea, which a whole host of sleep disorders. We're at the Brigham going to be launching this behavioral sleep medicine program. We're going to see exactly what that comprises. There's several local psychologists who specialize in sleep who are in the area. Most of them are concentrated in Brookline, but there's a few in the city and north. The Society of Behavioral Sleep Medicine has a website, how to connect with those. And as I mentioned, there's a few online resources. The one thing I would say, though, is even before coming to sleep clinic, I think the real issue is a lot of people don't talk to their primary care doctors about their sleep disorders. It's often the, as I'm reaching for the doorknob, going out the door issue for, I think, a variety of complex reasons. So if you are struggling, with insomnia or think you have another sleep disorder, again, it's not something that you can seek treatment for. Sometimes we see patients, who think that there's no treatments or they've tried everything. So it's worth talking to your doctor. And if you try things and it doesn't work, it may be a sign that you need to then go see some specialists. And sometimes it's actually hard to access some of the behavioral specialists, but we do have a wealth of them. We're really fortunate in Boston to have several very good behavioral psychologists who do behavioral treatment of insomnia, and we're trying to work on bringing it to more people through more accessible routes as well, but something we're trying to do.
Thank you. All right, well, thank you, Amy. Thank you, Dr. Shipp, Dr. Bertisch. This has been a fantastic, comprehensive presentation, so really appreciate all of your inputs and perspectives and grateful for your presentation. Thank you.